So acute heart failure is the commonest cause of emergency admissions in the over 65s. It accounts for 5% of all emergency admissions. The inpatient mortality for this group of patients varies vastly between hospitals, from a low of approximately 6% to a high of 26%. There's guidance which recommends how these patients should be managed via specialist pathways, specialist input. There's various investigations that should be done, treatments, referrals to palliative care, but we don't know whether this guidance is followed and whether the recommendations that are made are actually kept. So we looked at adult patients, so 16 years or older, who were admitted to hospital as an emergency admission and then died with a primary diagnosis of acute heart failure. And this was for the whole of 2016. We then selected a subpopulation of patients that died within 7 days, and we looked at a group of these in more detail.
Over a third of patients included had diabetes, and over a third had renal disease, and more than a quarter had COPD, and more than a quarter had had a previous myocardial infarction. As a group, they were generally very frail. We used the Rockwood Clinical Frailty Scale to assess the level of frailty prior to hospital admission, and 72% of the population had a frailty score of between 6 and 9, 6 being at least moderately frail. And that compares with 18% of patients on acute medical wards, acutely admitted to hospital, in the national benchmarking audit run by the Society for Acute Medicine.
So for all deaths for patients admitted as acute heart failure, there were 11,500 patients, and then when we looked at deaths within 7 days of admission, there's about 4,700 patients. So we had 3 main sources of data collection. We had a questionnaire that was sent to the consultant responsible for the patient at the time of death. We then had an organisational questionnaire which was sent to all hospitals that admit patients with acute heart failure. And then we had the peer review aspect of the study. So that's where we had copies of the case notes for each patient in the study. And then we had a group of clinicians who peer reviewed the cases using a focus questionnaire. So we received data from 603 completed clinician questionnaires. So that was the consultant who was responsible for the patient at the time of death. And then we peer reviewed 464 sets of case notes, and we received a completed questionnaire from 178 hospitals. So that was the organisational questionnaire.
So the thing that we need to improve in the care of heart failure patients, well, there are several things we found. The first thing we found was that people need to be reviewed by a consultant with an interest in heart failure, or a heart failure specialist team, more frequently. We also found that they need to be investigated more thoroughly. And finally, in this study where all of the patients died fairly soon after hospital admission, we found that they needed to see palliative care specialists more frequently. So we know from the National Heart Failure Audit that patients who are reviewed by a heart failure specialist have better outcomes. And we found in our study that only about a third of patients were reviewed by a heart failure specialist during their hospital admission. And yet, in the patients who were reviewed, 2/3 of those patients had their medications changed, suggesting that that's a valuable thing to happen. So we've made a recommendation that all patients are reviewed by a heart failure specialist during their hospital admission. The model for hospital admission for patients coming in with acute breathlessness or acute heart failure is generally that they come in under generalists before they're reviewed by the specialist team. And we therefore recommended, in addition to the specific recommendations about heart failure management, that every hospital should have a guideline that allowed people who are not heart failure specialists to understand the priorities in managing these patients when they were admitted to hospital, and that guideline should be audited on an annual basis. So there are 2 tests that are really important when investigating patients who come into hospital with acute heart failure, or potentially with acute heart failure. Firstly, blood testing for natriuretic peptides is valuable in diagnosing patients with undiagnosed breathlessness because it helps to identify patients with heart failure who therefore need further investigation. Echocardiography is also an important investigation because it helps to both diagnose heart failure and also guide the best treatment for it. And we found that both of these tests, natriuretic peptides and echocardiography, were not done in a lot of patients. The reviewers who looked at the case notes found that in a third of patients there were investigations that were omitted that should have been done. This was exaggerated in the patients with newly diagnosed heart failure, where there were about 40% of those required additional investigations. Natriuretic peptide, this key test that we've recommended is done in the first set of blood tests in patients who present with undiagnosed breathlessness, was only done in 17% of patients who presented with newly diagnosed heart failure. Once the diagnosis of acute heart failure is suspected, an echocardiogram can help to diagnose that it is heart failure and also to guide the treatment for each individual patient. And we found that again in newly diagnosed patients, an echocardiogram was only done in 44% of cases. So of course this was a study of patients, all of whom died within 7 days of hospital admission. So the need for or involvement of palliative care services was always likely to be quite high. And we found that in 25% of cases the palliative care team was involved in their care, but we also found that on review of the case notes there was another 26% where the case note reviewers felt that palliative care services should have been involved. The case note reviewers found that when they were able to assess this, that in 29% of cases they felt that the admission was potentially avoidable, and in half of those cases this was because they felt that palliative care could have been delivered in another environment rather than in an acute hospital. NCEPOD studies always rate the quality of care received by patients, and we rate good care as a standard of care that you or I would accept for ourselves or to be provided by our own teams. And patients included in this study had their care rated as good in 44% of cases. This was exaggerated then when we looked at newly diagnosed patients, where they were less frequently rated as good, and not surprisingly, when care was given by a heart failure team, care was rated much more frequently as good. Again, enhancing the recommendations about review by heart failure teams and specialist review.